Okay, so I'll just do a very, very brief introduction, and then I'll let Andrew and Rena really take over. But so I think we explained this to actors in the emails, that this is a training for behavioral rapid response, and Sheila's already been through it, so she can chime in wherever needed since she's the expert here. But essentially we have a rapid response team in the hospital where it's called when there are medical emergencies. And sometimes they encounter, and again you can jump in here as well, encounter behavioral issues, and the people who respond aren't trained in how to deal with delirious, agitated patients. So what we're developing here is a training for how to deal with that when it happens. It doesn't always happen. Sometimes it's purely, medical, but it does happen every month or two or something like that. And this is really to help the people who respond to these emergencies better deal with it. So this was developed both with the rapid response team, with the ICU clinicians, as well as with our psychiatrists. And so this is the agenda for today. We asked you guys, actors, to come in here to learn more about the content, right? So that when we do a role play, that you have more of the background and that you understand exactly what it is we're going to be teaching to the learners and asking them to do. So today is a pilot. So everyone in this room is either an actor or somebody who's going to be doing the teaching. So we're all learners in the sense that we're learning how to execute this training. But right now we don't have the people who are actually going to be trained in the room. We have 6 dates that we've already established from April to June, I think, or May, where we're bringing in the ICU, nurse practitioners, perhaps people from security, some RN nurses as well. So this is really for us to be able to flow through it, see how it all goes, make adjustments where needed, and that's really where we want people's feedback, and we want this is kind of it'll be like a bit of a back and forth and a discussion, and we're going to have to make some revisions, I'm sure. But this is our first stab at it, and any questions before we really start the process? Yeah.
I know that we have an outside person come in
Okay.
and do some
Right.
training.
Right.
And if either Andrew or Rena could just talk a little bit about that training and why we felt we needed to have something additional.
Okay. I'll let you guys do that, and then I'll.
Yeah, that's my perfectly interesting introduction.
Oh, is in your introduction?
Yeah.
Okay, so we'll hear about that.
The number 2, right?
Yeah.
And would you also be with the actors in particular, would you guys like to have some input into what the experience is, for instance, of a delirious patient?
You see that they're in the character
So we have the scenario, we have 3 scenarios. We haven't adjusted them to the correct demographics based on you guys. We just wanted to have that practice. But in the delirium one, Andrew actually said, like, imagine ... to really get you in the mindset of what a delirious
So
patient
there's
would
stuff
say.
that I think might be feel
We'd love
like
to know
to
it.
know.
100%. Thank you, Bill.
All right.
But
And-
the director might.
So
Wow.
this is going to be the first didactic, which is really focusing on verbal de-escalation. It's less the extreme delirious agitated patient, and that's the first one we're going to do. Again, we're going to first present the didactics, and then afterwards we're going to do a little role play.
And there are 2 modules that we're going to.
There's 2 modules, yes.
So
There's
we're gonna
verbal
do 2
de-escalation,
didactics, and then 2
role
role
plays.
plays.
Yep.
Yeah, so to give context to what we're doing here, a lot of this work that we're basing this off of, the foundation for it, stems from mentally ill patients in the community or in the prison setting who, for various reasons, due to their mental illness, were coming to the attention of police officers. And there are several cases of police violence that people question could have been predicted or prevented. So, for example, San Francisco has enacted a program for specific people who are trained to de-escalate and calm down patients with mental illness. And that's expanded, and that's been the foundation for a lot of what's happening in the hospitals around us, that there is an approach to try to help de-escalate patients with schizophrenia, intoxication, mania, and so forth, who could have potentially avertible crises. So we invited actually someone from the Riker system who's developed a similar program and I attended a different program called CPI, Crisis Prevention Institute. But the main hurdle that we ran into is all these programs are developed for the community, where physically healthy patients who could potentially withstand more physical force, for example, or who may have a mental illness that they can acclimate to, as opposed to a delirium picture, which we'll discuss a little further, that it's harder for them to engage verbally. So we wanted a program that would allow for medication use, judicious use of medication, and tailored towards our population of medically fragile patients. So I don't know if that addresses your thoughts. So the idea is that we'll have this behavioral code, and the main learning objectives, at least in this module, is know what you need to know before going into the room. And that involves how do you assess the patient, where they are, and then tailor your treatment accordingly, whether the person is appropriate for verbally de-escalating, calming down with communication skills, or at what point do you need to use more extreme measures for their safety and your own.
Can I ask you a quick question? Do you want us to talk as we go along, or would you like to give it all and then make notes of?
So I would like to be more open-ended, but
You want to go through the C?
but I'm worried about time.
Okay.
Is it the word code?
I just, yeah, I
To
mean,
clarify that.
yeah, I just wanted to.
What was your thought?
I think given that what we're trying to do, it's probably good to go through it, or at least, go through half of it and then maybe stop or something.
Yeah, sure.
But I just wanted to see what your preference was. So
My
as-
preference is open, leave it
Okay.
open, if you guys have time.
Okay.
Yeah.
We'll see how it goes. I just
We should
wanted-
try to stick to the agenda as much as possible, but
Yeah,
comments, obviously the whole point is that this is supposed to be constructive and helpful in moving us forward, so.
okay.
So in our setup right now, we have the behavioral codes will be directed first towards the intensive care team, who have the opportunity to be there first on the scene, and then enroll psychiatry as a consult to be incorporated. But just for expediency, and just because the nature of these emergencies can be so fast, we want to make sure it's a team of individuals who are familiar with the hospital and can arrive within a few minutes. So the program is geared towards people in the critical care department.
Just to add, we're hiring several psych MPs who will be taking night and shifts from 8 p.m. to 8 a.m. So you'll have someone from psychiatry in-house immediately available all night and all weekend night.
I guess we can talk offline about the flow and then we anticipate that we going on.
Yeah, so we're hiring them now, probably to train them.
So we'll wrap up this module by discussing how to sustain improvement and stability. By nature, a lot of these conditions are waxing and waning, people coming in and out of crisis. So the important thing is coordinating with the team on the floor so that the patient can have some sustained stability over time. So before you go into a room, there's the key component of preparation. And the goal is to get as information that you can quickly collect as relevant, the most relevant first. So offhand, I'd like to try it open-ended, like what are some questions you have when you're called to an emergency behavioral code, maybe open to everyone, but that you'd want to know about the patient?
Well, I want to know what kind of cancer they have, how sick are they,
What are they?
how frail they are. I want to know whether there's been a pattern of behavior that's kind of been brewing, whether there's been a fluctuation of mental status over the course of a couple of days. What any events occur that might have precipitated this, stuff like that.
What meds they're on?
Medications or?
Meds that they're on, any, metabolic arrangements, things.
Sure. So is this someone who has been sort of, you could see him brewing all day, you could see him pacing the hallways, for example, to be gender normative, or she recently got she's been in the hospital for days, up and down, it's been unpredictable course. And so all of a sudden someone who's very pleasant and cooperative, and now all of a sudden is this abrupt shift in mental status.
Or other episodes of agitation, would want to know if psychiatry's been following the patient throughout cycle.
Would you wanna know if they have a support in-house with them?
Right, absolutely. So what's available to you, what are your resources available in
Or
terms of
family
a
members, or,
family?
yeah.
Yeah, exactly, who can help you, either in the room or outside of the room, or in the same country, in the same state, same city. So just distill it to what to sort of this triage mentality is the most, I consider the most important thing, is just how are they able to talk, if they're able to talk. We see a lot of patients on ventilators, who are, some can tolerate valves, some can't tolerate valves, can they speak English, just basic, that's gonna be the first, how you're going to treat this person, the first, roadblock. Any recent history of violence, has this person been causing a lot of disruption to the floor? And that's one of the best predictors of violence, future violence, is past violence. Try to get a sense if that's the case to whom, is it to nurses, is it to family, does it seem to be volitionally directed, or is it seem to be random? And to that point of who's there, who's with them, are they people with them to help or be a potential exacerbating factor? The way we want to get into the medical history, but be as judicious as possible, but to arrive at some of the points, medications, and some of the points you're mentioning. And this, because we're tailoring this towards our hospitals, what I would consider to be the most important would be pathologic fractures, lytic lesions, thrombocytopenia, and that's going to immediately inform what type of intervention and degree of intervention you can offer. But certainly, if they're on high doses of psychotropics, those are things that could generate falls risk. Those are things that are also, as you proceed, you want to be aware of. And then you want to know what you have. So this is all with the mindset of what you have at hand available to you to help this patient. And this is one of the first things, as a psychiatrist and patient psychiatrist, when you're responding to an emergency, you want to know, as a fail-safe, are the medications drawn up? The last thing you want is to be an emergency situation where you need to use a medication and it takes 20 minutes to get through the system, or there's some fumbling, or this is going to be a high-stress situation. You don't want handshaking as they're drawing up medication, so you want to know if that's been available. You want to know where is security. Are they nearby? Are they present? Are they aware of what's going on? And to your point, are there family members or friends? I mean, we start with medications, but ultimately the most effective interventions are the people the person's familiar with. And what's going on? There's always generally activity. I think what we find here a lot at Sloan is that people are always trying to help. So there might be multiple people trying to help a patient at the time, trying to get a hold of their loved one, trying to get them some food. And it's just helpful to know what the situation is you're walking into.
Patient background.
Yeah.
So, those are important, but I sort of came up with like a half dozen more. What do you do with all of those?
So I think as a distinguishing between what a
I do
psychiatrist,
think they're not that critical.
I think it's being able to triage for a non-psychiatrist, a non-psychiatric team. I think those are all important things. But I think I was just trying to think of what are these the most immediate.
So you don't want to overwhelm the
Right.
team with all these things that they need to know.
I agree, because usually, it gets very chaotic.
Yeah.
was gonna say,
On
yeah.
the floors, it gets so chaotic, I think the focus should be just simple, like maybe, develop simple tools for our team that we can apply in a very chaotic situation where we might not get a lot of the history, we might not get a lot of the information, we might not get a lot of pertinent information that's been occurring during the day. It's just, that's the nature of the game. That's what happens when there are RRTs that are very sick, or somebody that's very delirious. That's what I'm going to foresee happening.
I'm sorry, I don't think it's an overwhelming, these are things that, as psychiatrists, these are things we think about. Is a person communicating? Have they been violent before? You guys are already gonna look at all of that medical history, right? You're gonna know all about the meds,
Yeah.
the labs, the this and that. That's intuitively how you approach the problems. But I think a couple of these things, even if you walk away with, have they been violent in the past? That's such a big predictor of
Agreed,
future
but
violence.
what I'm saying is, we go in, we're giving Haldol, Ativan, whatever, depending on the situation. Hopefully, by that time, you guys are also showing up to the scene
Right.
to do a more comprehensive workup.
Right.
Depending on the situation, but
You want to know the 2 or 3 things you need to do
Yes.
before you get
and Deborah, please feel free to chime in, but I anticipate if it's that much of an emergency, we're not gonna get a lot of information. We're probably going to be putting in IVs, because the patient's probably pulled it out, to give medication, holding them down, like figuring out what to delegate to security, figuring out what to delegate to the RNs on RT. So, and pharmacological therapy, but I'm just worried, I'm just concerned that, like some of this more comprehensive stuff, which is good, which obviously we always want to be thorough, might not be done until your expertise shows up. So Deborah, please chime in
Yeah,
as well.
no, just to chime in. So I think that Dr. Breitbart, you raised a lot of important questions, but what makes this layout a little bit more practical for RRT is just understanding that we get a page that says show up here at this location. There's no time beforehand to look through the chart. You just have to show up. So as soon as you get there, everybody's freaking out, everybody's up in arms. These questions hone in on the immediate things that you need to know. And then once we're able to sort of see and understand, okay, how do we at least communicate with this person to try to calm them down or have an understanding of whether or not they've been violent, et cetera. Like, this is what we need to know. And then in our secondary assessment, we can get more towards the questions that you were raising.
Yeah, and I think the overarching goal is, this is a chaotic situation that we're trying to create an algorithm structure to. So in the same way, when you have a code for a cardiac issue and you just do BAC and it's not trying to get into electrophysiology, it's not trying to get into etiology as much as what are the steps. And so the most immediate concern at this point is what do I need to know to keep myself safe, to keep the staff safe, and most importantly, keep the patient safe.
The only other thing I might add is placing people at risk of injury is adding anticoagulation under thrombocytopenia.
And also, just along those lines, when we do get into restraints, maybe a slide on what are the contraindications to restraints. I don't know if there are any, but if there are, these are some, or at least some consideration. Again, what's in security's roles and responsibilities, and the policy states that they can apply restraints, are they already, like, et cetera. When we get,
Save it for.
Yeah.
Perfect. Quick question. The last one, our staff in the process of meeting patients' requests, what exactly is that one?
So, yeah.
And why is that so important?
It's just a situational awareness that, and this is ideas speaking of what are the resources available right now. So we had one patient on the neurology floor recently who was amnestic, couldn't remember anything, and by the time our fellow had arrived, it sounds like one group of people, one group was like trying to get him food, one group was trying to reach his wife, and there was a lot of chaos involved and there was no clear leader. So part of this is, again, trying to organize this chaotic situation and seeing what are the forces around this patient going on. You don't want to be taking one intervention while someone behind you is bringing in, you're not, if you're thinking I need to remove all, throw objects that can be thrown, and then someone comes in behind you with a food tray, that's something you need to be aware of.
Agree with that?
I mean, I think it's simple. Just simplifying is better. Like, if you're calling an RRT, most of the time we try to have somebody that takes control of the situation, that identifies themselves as kind of leading it. Yeah.
That's what I was thinking would be very critical.
Yeah. So, just like, again, very chaotic situation, lots going on. All these nuances are very important. Considerations are very important, but just simplify, like, boom. When you go, obtain control by this way, think about safety, these are the considerations, introduce yourself, like boom, 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 just kind of like things that, that somebody can just walk away with, and also obviously bring common sense into it.
Right. So these are things you need to know before you actually walk into the room, right? Do you think there should be someone that's designated as the leader before you walk in the room?
Usually the APPs lead the RRT. So there's one APP assigned. You'll have RNs on RRT that'll go in. You'll have nursing supervisors at night. You'll have a nursing educator or CNS probably go in day and night. But the APP, the NPPA on our team is the established leader. Everybody kind of knows that, right, Deborah?
Yeah, it's implied. They're
It's
calling
implied,
you
right?
as soon as you show up, you're automatically the leader. Even if you know nothing, you're the leader. You're leading it. It's just, that's it.
So yeah, at this point, we're still not even in the room yet, but that's the question is asking, who is the team leader? But that, from there, establishing roles, so in the same way you wanna know who's bagging, or who's getting AT, or who's collecting collateral, you know, say, it'd be good to designate someone, all right, can you get more information on the patient, get the more details.
So is that your actual next slide?
It wasn't my next slide, I can move it up further, if that's something that you
So
feel
why
like
don't
would
you
come
go
in
through what
next.
you have?
Okay. So this is, as again, we're going this triage mode, that these are things that are important to get down the line, but not necessarily urgently. Just something to keep back in mind. To your point, what is their baseline mental status? Is this someone who's coming in from a nursing facility, who's got limited mentation to begin with? Is this someone who's been an independent person living their life normally? And this will help you sort of conceptualize the patient. Psychiatric history, I just want to make a mention that people pick up these diagnoses in the chart, through chart lore, but if someone, it would be very uncommon for someone to develop schizophrenia late in life, or bipolar disorder, and this will inform, and Rena will get more into, you know, informed choices in medication, but just something to be aware of. It's important to know if they have a history of suicidality at some point, and things like substance use, if they're drinking daily, any changes in their pain regimen, one way or the other. Again, this is informing treatment decision down the line, not necessarily the first questions you're asking. So I could move this slide later if it's helpful. And again, recent medication changes, steroids in particular, and benzodiazepines.
Quick question. So a lot of delirious patients are delirious because something really semi-catastrophic is happening medically. So that might be like severely hypoxic. Right? Or they're a renal failure, or something like that. So, you get called for a regular rapid response team for someone who's, let's say you've come to see patients who basically are they're in respiratory failure, right? What do they look like when you get there? Are they agitated or?
So it depends. Every patient is different. Some patients are cognitively limited, but yet hypoxic, but there are certain subset of populations that we're called just because they're very agitated. And, you know, within the first few minutes, as we're assessing the patient, we realize there's something toxic metabolically driving this.
And how do you figure that one out?
Well, how do we figure
You
that?
get like a pulse ox?
Well, again, it's vital signs plus the story. We developed a certain way of asking questions, you know, being on a rapid response team, the APPs are pretty good about it. We kind of get to the bottom of things very quickly. We have to figure out what is really going on. I think the team, Deborah, I think most of the team members are very comfortable in getting into the bottom of what's really going on in the first few minutes. So, you know, we're able to quickly identify, okay, this is somebody has ARDS or ALI, acute lung injury. This is probably what's driving the delirium versus, you know, an infection. You know, just, I think the team has a sense. We do our investigation, we do our review assistance with the patients, as well as a review assistance or going over pertinent stuff with the team that's there. And we're able to get a story or make a story or connect the dots very quickly, most
So
of
would
the
that
time.
be anything you put in the slides before you enter the room?
Before we enter the room, we have no idea what's going on until we get to the room. As Deborah said, we have no medical record number, we don't have time to review the chart. It's, we show up, how may we help you, what's going on? We start hearing information from the nurse, it might be accurate, or it might be missing information, but we'll keep asking the information, and somehow we'll get all the dots and start connecting them.
I think one thing worth mentioning, and I don't know to formally put it in, but a way of quickly distinguishing behavioral versus non-behavioral emergency is the staff response. And it's not definite, it's not synonym, quote, whatever type thing. But if typically, I feel at Sloan, particularly, like if there's a medical rapid response, everyone is on scene, knows exactly what they're doing, there's an organization. When you see the staff is like more disorganized than the patient, or equally disorganized than the patient, that means that they're eliciting a lot of emotional responses from the team, and that might be the first observation to make that this is a behavioral in nature. It's not.
I don't think we can assume,
Not
to be honest
clinical,
with
but-
you, because, you know, there are, you know, patients that don't have behavioral emergency.
Mhm.
Now, behavioral emergency, is it coming from something underlying toxic, metabolic, or is it coming from something that's totally psychological? That is something that we might not be able to know right away, but we might get to the bottom of it. And again, you know, if a patient needs to be intubated, started on vasopressors, we think they're septic, we'll do A, B, and C. But if there's not any of those, or maybe they have delirium with an underlying psychological problem, like, I feel like you guys are up there to help us out, help the patient. In terms of your questioning, you know, the level of chaos.
It's my plug for psychodynamics, but I'll just.
It's the same,
Yeah.
Deborah, I think it's really the same. You could have a patient that's really sick, doesn't have a behavioral emergency, but there's still that level of disorganization. We're actually trying to work on that throughout the hospital by making pre-emergency roles, and we're trying to improve that. But I'll be honest with you, I think that is always going to be there. No matter how much education, you know, you bring in, there'll be an element of that.
Okay. I think basically there's two choices. Is this delirium, which then puts it into the barrel of what you guys are used to dealing with. You're used to dealing with people who have something bad going on medically that is causing them to be agitated, delirious. And then there's the folks who are not delirious, who have psychiatric illness that's getting out of control, something like that, or personality disorder.
So let me get into that a little bit.
Would you,
Just
would
to
you
add,
prefer that the slide just be thinned out to that? Like, is this, try to quickly assess, is this related to physiologic issue versus is this
Pathological.
personality or even substance?
I don't know, and I'll get into that too. I don't know if there's a distinction necessarily worth making. But I'll kind of make my case for that.
For purposes of verbal de-escalation?
For purposes of what we're doing.
I'm interested in seeing a little bit, you know, like, I think all of our thoughts are great, but I'd like actually to see more of the slides, because I feel like I'm not
We're
getting a big
getting ahead of
picture of,
ourselves.
yeah,
Go ahead.
I think so.
So still in this practical
Just
mindset.
enthusiastic.
So who's reaching out to the family? So make sure that these are sort of how you partition the roles differently in the behavioral emergency. So they make a good point that we may not know if this is behavioral or not at this point. I think regardless, every module, take your own pulse before you take the patient's vital signs. You have to be able to come as objectively as humanly possible before you go in. Be mindful of your own emotional responses. Particularly, it's always helpful to know if there's a certain type of patient that elicits a lot of specific emotions to you. Again, this is more of my psychodynamic side coming through, which can be edited as needed or censored as needed. But generally, if you can figure out that there's a non-medical urgency, you make a good point. We might not know at this point, but try to limit the number of people actually entering the room to 2 to 3. And then, but before you walk in, know at what point, what are the thresholds you're going to need for bringing more people. If the person seems more medically ill, more medically fragile, or if the person's about to leave the room, or you need to be able to communicate with your team before, have a sense of if this person jumps up or jumps out, that's when we're going to call in to get someone has to go out, get security in here. Once you're actually in the room, again, these are all common sense things, but we're trying to just put this out on and make it as organized as possible. Do they have their clothes on? Will they be able to easily, if they did leave on the street, are they going to be able to elope easily, or are they still in their hospital scrubs? We want to make sure whatever is in the room it's attached to the patient, whether it's a line, Foley, or equipment that it can be thrown, and see what's going on with the family members. And that can go both ways. Sometimes they're antagonizing, and sometimes they're actually, most of the times they're helpful. And then we're saying try to organize your team to get the family involved to help with the family.
That was really like sometimes, occasionally you're there, you walk into a room, the patient's like already dressed, ready to leave, right?
Right.
Is that what you mean?
Yeah, exactly.
As opposed to being in bed and there.
Right, that's something to take stock of. So we're now actually in the room. Before we're outside, now we're in the room. And then what's the patient doing? Are they tensed? Are they relaxed? Are they making eye contact or looking around the room? And Rena's delirium lecture will get into the mental status changes associated with delirium that should be watch out for. See where their focus is. Is it on you, or is it on the doorway? And do they have access to that door? I think it's important. And this is my feelings. Unless you're feeling particularly agile that day, the patient should have a sense of that they can reach the door easily. My preference is to keep an open posture if it's unnatural to you, to be at an angle to a patient, but the idea is if you're squared off to a patient, they're just going to see a wall and a barrier for exit, and that's just going to elicit more of a fight or flight response.
So you really want the patient to be able to feel like they can leave, you don't want to feel trapped.
Right, exactly.
And you have to be able to have a way to get out.
So yeah, so in this, that's why I put in this, so that you can leave too. Just to really, to hammer home that point. But that's just part of the situational awareness. It should be tricky if you're assessing for medical. I mean, a lot of our nurses are harmed when they're reaching over to your vitals or checking on the patient. So that's part of taking stock of the patient, like they've been violent before. So this is how I conceptualize it, and why I don't know if the distinction between psychological or medical is pertinent in our environment, because I think it goes hand in hand. When conceptualize this adaptation of the distress thermometer, so this idea that when we're functioning at our best, we're adaptive, we're able to take things as they come towards us and make changes appropriately. And when we're at our worst, we can be a danger to self or others. And the ways we go up and down this thermometer is basically a balance between our physiologic and psychologic reserves and supports around us versus what the insults and the stressors are. And I'll explain a little bit more what that looks like. So let's say someone has recently been diagnosed with cancer, and they're developing this sort of neurotic pattern of thinking. And they're doing basically this idea of maladaptive coping, doing the same thing, expecting different results. It's probably not where you're going to be seeing the RRT, but that's sort of the goal, in a way that's trying to go a goal to get them there. Then they start to develop, as things get worse, maybe medically or psychologically, they might have overvalued beliefs and they're stuck in their way in their thinking. It's not bizarre necessarily, but it's the idea that it's hard to move.
Would you give an example of that?
Yeah, like let's say someone who, my example I use a lot is someone who has like this very strict ovo-lacto vegetarian diet at Whole Foods, but like extreme. Something that they are convinced is healthy, that there's good evidence for. If you look on Google, if you Google for it, you'll find evidence, and it's hard to move them, but so that keeps it from being delusional, is that it's not something that you develop on their own.
If they're in the hospital, they believe, I really need this test, and not giving me this test. I need a CAT scan, I need a CAT scan.
Right.
Or I've been waiting hours for this CAT scan, and it's very important to me.
Yeah.
I don't think this CAT scan is terrible. That's wrong.
That's much better than my much more offensive example. Apologies to all the ovo-lacto vegetarians. But yeah, exactly.
So all the Gersonites.
But you see it in the psych hospital, in psychiatric floors. You have patients who just become obsessed with tomatoes are poisonous because red, and that's a psychotic behavior versus someone who's red or belongs to a select group of people and keep kosher, for example. Then as we go down, there's this absence of defining traits. We hear a lot from families, and it'd be interesting to get some of your narratives from the delirium projects, like this idea that this isn't my father here, this isn't me, I don't know what's going on, and then you start to get into more dangerous behavior. When patients start to have difficulty testing realities, I can't get the CAT scan because a cat scratch will get me infected. So there's this this loosening of associations, and this is when we might start to see behavioral emergencies. And then when it gets really worse, when you get into this hypoxic state, for example, there's loss of control of your actions. You're not thinking before you act, or you don't appreciate what you're doing. These are the examples. And I think we all intuitively know this, that, like, for example, someone who's getting a little tipsy at a holiday party might not be acting the most appropriate coping way, but it's a different entity than someone who's had PCP. I'd like to go over these.
So
but
this is
we're
almost
out of
in
time.
order of the behavioral emergency, like you're putting delirium due to hypoxia in the highest risk behavior. This is
Right.
like the behavior spectrum.
Hierarchy, yeah. So going back to the example, someone who's just learned that they have cancer, and they're coping in a way that's not helpful, versus someone who has a mild depression and they can't really, no matter what you suggest to them, everything is being perceived as I'm a failure or I'm awful, and there's little movement there. Say personality disorders, everyone has a personality. At some point it works to their benefit, at some point it works against them. Someone with a severe personality disorder consistently and persistently has problems due to their personality. The stereotypic example we use a lot is borderline personality, someone who has that lost sense of self, perpetually, chronically, and we see them in the clinical situation scenario a lot because they're often presenting with suicidality, these extreme behaviors, this desire to be helped, at the same time rejecting it when they actually are offered it. And that actually might be something you see in behavioral RRTs as well. And even though they are experiencing, there's always, and that's why I don't think it's helpful necessarily to distinguish physiologic from psychologic, because there's someone with a personality disorder that's been stable for years and they've adapted and coped, but now they're anemic and they're not mentating well, or they have some physiological component that's adding to it, that's just adding to the burden. Delirium due to narcotics, I'd say that there's generally intact reality. The reason I put this above is that there seems to be more intact reality testing, that patients can identify after a while that they're having hallucinations and work with it, but initially if they are charged up, if they are anxious to begin with and they do experience this, they can become very disinhibited and it can quickly escalate. And then the delirium due to hypoxia, I feel looking at the literature, what is treatment refractory for olanzapine, for example, and just from personal experience, anecdotal, that this seems to be the most severe. And the reason why I arrange it this way is because that's how, when you are in this rapid response, how you're going to be dealing with it. I mean, the higher levels is probably going to be a case where you're just trying to buy time for psychiatry to get there and work with them. But that will involve, once the person at the top maybe be more interested in problem solving. Well, I'm hungry, let's get you some food. And then someone going further down, they might need more limit setting and structure, support. And a lot of times, and then once you get towards the middle area, this is where you're starting to lose the ability to use verbal de-escalation, but you're still there. There should be a way at least calming and soothing the patient with words. Then,
I just want to add, I know we still have to, I think at some point we should sit down with Dr. Halpern and go over all the criteria again. But what I anticipate from the past meetings is most of the times we will be called as somebody who's truly just disruptive, threatening, maybe violent. So I think the group will most likely be responding to those scenarios rather than somebody on the spectrum where they're, there's room just to counsel them and speak to them.
so
You never know.
I'll give you an example of a patient who came in, is on our consult service right now, and you can tell me if this is something we would address. But there's a long-standing history of substance use disorder, who has a history of breast cancer that has been treated multiple times, but with several recurrences, and never a good candidate for surgery because of concerns with IV drug use and healing and social support. And it got to the point where it was emergent, and they were worried it was becoming, I don't know exactly what the criteria was, but the breast surgery team decided to admit this person to the surgery almost emergently without plastic surgery in agreement. Now the patient is in the hospital with mastectomy and but without opportunity for reconstruction, potentially withdrawing from substances, acting in a maladaptive way. She has a history of multiple incarcerations. She has children who we're not entirely sure where they are. So this is someone who could very easily erupt into a behavioral emergency, but not necessarily someone who would be your first stop is just load them up with medications. They're still amenable to some sort of conversation. And I think it's important when you see that person trying to figure out, all right, is this something that I can just, there's an easy, quick answer that I can offer? Do I need to set strict limits? Do I need to like try to, and I'll show you some verbal de-escalation techniques, or do I need to rev up and start?
Right, I do
security?
agree. My only thing is, again, when we meet on a separate day, is like the expectations until then, at a certain point where you are calling the RRT. Before that, maybe education in terms of the prior routines, get psych involved. For example, there is an algorithm built up for patients that have substance abuse withdrawals, or potentially have substance abuse withdrawals. Like, were those algorithms already applied? So, I just want to make sure that the message is not that any kind of anything on the spectrum that's not that serious, call an RFP. I don't want that to be the message.
Yeah, I view this as being for us to know, and then as you guys create criteria for calling the RRT, that should be something separate.
Yeah.
I agree with you.
You probably will
So
be
let's-
called for maybe verbal de-escalation stage, maybe not even that, but given medications and on identifying the underlying codes, right?
Yeah, so the way I would do it, and I think the way we should do it starting next month, is sort this out beforehand. Criteria, this is what we came up with. Behavioral emergencies activated based on this criteria. This is the workflow. APP, RNRT, security, RRT, APP expectations. Consider verbal de-escalation. When to consider pharmacological treatment. How do you maintain safety? Etc. Situational awareness. And then always address the critical care issues. Psych is also on the way. Like, something very simple, just to the point.
If you go back to the previous slide, so maybe this will be in your differential diagnosis, but not necessarily in I like the way you put it, but I wonder if it will be confusing to a non-psychiatrist who's not so familiar with the
Yeah,
concept.
it's too sophisticated.
It's very good, but it's
Right.
more for psych and
So I'm running about 5 minutes over, so I did abbreviate.
That's okay.
I think, I guess the question is, do we have enough time to really delve into each of these examples?
I wouldn't delve too much into it, but I
Yeah.
do like having this
Air
spectrum
levels.
up there so that I know where we're at, because Gibran, I think we're going to get called for people that still can be spoken to,
Mhm.
just like we get called for people who are taking agonal breaths when they're already DNR.
Well, and it
So-
also changes over the course of your interactions with them. It can go,
Yeah, so I'm interested in seeing where you go with this, so because I don't have a sense of where we're going yet. I really think we need just a run through so that I could see where we're going to really give more valuable feedback.
So I'm 5 minutes over, so I don't know what.
How many slides do you think you have left, or how much time do you
I have
have?
maybe 10 minutes more. I could.
I can go very quickly through the stuff.
But to that point, the way I see this progressing is that, yeah, you guys are going to be called in this danger area. And then after you make your intervention, maybe you get some medications on board. They still need to have some time and metabolize it. And then maybe they're doing a little bit better, they're getting more cogent, but then all of a sudden something will set them off, or some event will set them off, or some experience, some internal experience, hallucination, and they'll go back down into this ideally less intense distress, and that this is a lead into this idea of debriefing, is that you want to lead the team, that your goal is this acute intervention to get them to this point where psychiatry get involved, come up with a safety plan, work with the nurses on the floor to say, all right, what's setting this person off, so that you hopefully don't have to be called multiple times in that night. But the idea is to decrease the frequency and intensity of these events. So yeah, you might be called in at this low point, but the goal is not necessarily to get them 100% better, just to get them back on their feet with a plan in place. And that's the way that the acting scenarios is set up, is that it's a part of the exercise is rolling with the punches. Things are seemingly better, you're able to talk to them, and now all of a sudden they're getting worse and you have to make a change in plans.
Yeah.
100 feet.
I think it's always good to have verbal de-escalation in your toolkit, regardless of where you're at in the spectrum, because even patients, you know, I had a patient who severe hypoxic respiratory failure. She needed to get intubated, but she was screaming and yelling, and we couldn't get to the bed to even help her or evaluate her, and even to give her meds to calm her down. So I think
It's a very good point.
it doesn't really matter what the underlying cause is. Sometimes you need all of these other things
It's a good
in the
tool to
toolkit.
learn.
Yeah.
I mean, the class 2 months ago, it was definitely, like, there were some good bullet points that I took even in my personal life, just to have, you know.
Yeah.
You never know when you will use it.
Yeah,
So-
I actually like the flow of this and the outline and how it sets it all up.
Yeah. So I have a friend who's a naval psychiatrist, and he I don't know what he called it, he shipped it down to Puerto Rico, and part of what he had to do was just be next to a woman who was delirious after a hip replacement on that ship, and so part of, I mean, even though she was experiencing delirium from very clear etiology, having his presence available to verbally keep her calm allowed her to ride a helicopter on and off the boat, and there is some value to it, even if we are medicalizing the situation. So, I mean, to get to the nature of like, how do you get that verbal de-escalation, and these are sort of the big bullet points that we're trying to draw from Anthony Walker's course as well as some of the other courses, is this idea that ultimately the patient should be in control of what happens to them. That you should, the idea is to get them back, whatever you're doing is to get them back in control, whether it's through the
By
medication.
successful intervention, you mean verbal de-escalation?
Any intervention. So whether you're giving them medications, the
See,
idea
if
is.
I'm listening to this, I want to be trained, I want to know how do you do verbal de-escalation?
Yeah, so I could jump right to that.
Okay.
So the first step is broker trust, and the way you do that, that's the strategy. I hope I'm using the concept terms. That's the strategy. The tactics are that you validate. One tip and trick is to validate emotions without disputing facts, and that's something I think we all benefit from, like you're saying, in personal life as well as clinically. Patients will be making some very bizarre accusations, and it's very tempting to leap on them and say, no, that's absolutely not true. But it's important to identify the emotion behind it. And I like to take it up a notch, so that sounds something that maybe a patient's a little scared of. That's absolutely terrifying. That would terrify me. I may not agree that they were transported on a spaceship to the CT scanner, but that sounds horrifying that you could just wake up like that. That being said, if a patient is discreetly paranoid, you might want to curb back your empathy. Like, I really want to desperately help you to someone who thinks that you are imprisoning them. They're going to get suspicious of any intense emotion. So at that point, you want to take a more neutral tone. Always offer choices. I repeatedly go back to my toddler when I give lectures like this, but do you want mommy or daddy to brush your teeth? Do you want the Paw Patrol toothbrush, or do you want the grown-up toothbrush? So they're going to brush their teeth, but they at least have a sense of, and this goes to the idea of autonomy, that you're getting them back in control. If you can't get answers, if you don't know exactly what's going on that's causing this, at least discreetly, try to get at least an understanding where they're coming from. That's a more abstract term, maybe stick with more concrete ideas. But so the balance between autonomy and then setting clear limits. You have to know right off the bat what you can and can't offer, and you can't make promises that the team is not going to be able to catch. You know, we're going to get you better. We're going to get rid of this cancer. We're going to fly in your mother. Discharge you, right? Yeah, we get that a lot. Like, oh, the team last night told me I'd be discharged by the morning when there was no plan at all. You might solve that problem right away, but you're going to be called back pretty quickly. It's always helpful to give permission to do what they're already doing. Like, they're pacing the floor, like, right, you need to walk this out, great, go for it. Let me give you some space. But the most important thing is limits need to be simple, consistent, and enforceable. You can't say, if you try to leave the hospital by tonight, I might have to do something that I don't want to do. It should be clear, like, if you walk out that door, I'm going to have to call security to hold you. And it's a very simple, and the idea behind any limit is that it should be established before you lose your own cool and temper, that it should be as neutral as possible. Like, this is just, we're going through, and I often say this to patients, it's like going through the airport. Nobody likes it. This is just what you have to do to get boarded. You have to take off your shoes, and it's just much quicker. You want to get discharged, I get it. This is the fastest way. I can't guarantee it tonight, but if you follow these rules, then we'll be on the same page. We talked about taking your own pulse before going in. Some other verbal escalation, de-escalation pearls, you can see that's a spectrum too. The most simple and basic thing you can do for someone is mimic them. So if you're sitting across from someone and they're relaxed, you don't want to be crouched up right in their face. You're doing what they're doing. You're where they are. And there's nothing more calming than seeing that reflection. Stop me from overstating. But if they're making statements like, this is so frustrating, this is painful, this is, sometimes you can just say it right back to them, this is really painful. The more advanced, as you establish more of a trust or you feel more comfortable, start naming that emotion. Like, I guess going back to that example, they're showing signs of fear instead of just saying, CAT scan, like, I don't want to go CAT scan, you don't want to go CAT scan. The next step would be, that sounds terrible, yeah, CAT scan sounds really scary. And then once they hear that, and they hear that you're listening, then you can start working on clarification. Like, well, what exactly about the CAT scan is so scary? The problem is if you go too quickly, if you try to clarify or answer their question before you've established who you are, that you're a stranger, you're coming in from nowhere, you're rushing in with a team, they're not going to respond well to that. So you have to, again, the idea of meeting the patient where they are in that distress. You might have to go back and forth. But be ready, so it may be you feel like you're clarifying, things are going well, and this is something we worked a lot with Anthony Waters, that you have to be ready that things might go back all of a sudden, something might trip up the patient, get them upset, and you might have to go back to reflection. And this again, so some example, you walk in, patient right away, get out of here. I'm just going to throw some things out. You want me to leave would be an example of, maybe not open-ended at this point.
Paraphrasing? Almost paraphrasing?
I want you to leave. You want me to leave. It's a reflection. Hopefully, yeah, so it should be liaison obvious in this case, but because of the way it's framed, but that's just saying